I'm always worried and nervous when people use the term culturing a lot because that often drives antibiotic use. And so, I mean, if it's culturing in response to, you know, a syndrome that looks like an infection, I'm all for it. The other comment I'd make, and I use this analogy all the time with the residents on rounds, is that the ICU is basically like a funnel. And we've got at the bottom of the funnel the intensive care unit, and it's a collecting bin for resistance genes. And at the top we've got long-term care, nursing homes, the floor, other hospitals, especially in a system like ours. And so all those resistance genes make their way into the intensive care unit. And interestingly, you know, and one of the things we haven't brought up yet is this issue of healthcare associated infections that are community acquired. All that means is that those are infections that occur outside of the hospital that come in, but they're still due to antibiotic-resistant pathogens.
Because they got the antibiotics somewhere else.
Or they had contact with the healthcare system, and now they're back out there, and then they come back. And that makes up a large, significant pool, even more so of the pneumonia patients that we see than ventilator-associated pneumonia. I mean, those are now hospital-acquired pneumonias and healthcare-associated pneumonias in our intensive care units.
We go back to something that I heard when I was a medical student, so this is not new, which is patients demand antibiotics from their primary care physicians. I've got a cold, I've got an earache, I stubbed my toe. Can't you give me a tertiary antibiotic of some sort? And the doc says, sure, here's a script. And the next thing you know, send us your tired, your poor, your Pseudomonas.
Well, I think it's a little more nuanced than that. I think the point about antibiotic abuse in the community has a lot to do with resistance for traditionally utilized community-focused antimicrobials like levofloxacin or what have you.
Okay.
I think what Marin is really alluding to and what he's published extensively on are these patients who are in the iron triangle of healthcare, where they go from the the hospital, from the ICU to the floor to the LTAC and then back, and while they're at the LTAC, someone is treating them with antibiotics because they can do something, and there's this cognitive bias that doing is better than watching in medicine, which actually is probably clearly harmful. And what happens is that this person never actually is in the community, and so they're continuing to be exposed to healthcare. They're probably in an environment where there's poor infection control. They're getting antibiotics, and when they get sick, they show up to the emergency room, and the original prescribers in the emergency room are saying, oh, well, they came from the community, so it must be pneumococcus. And they're missing the fact that this patient's actually never been in the community.
But this goes to your point, right? You're worried that people culture for the sake of culturing, but if they were to culture in the LTAC and treat specifically with some laser-focused antibiotic, that might be better.
You know, I think it would be better if clinicians were focused on treating infections, but too often, the patient has a mild temperature spike, and, the trigger reaction is just to go right to the antibiotics as opposed to really thinking it through and maybe just watching that patient for a period of time.
Oh, that's hard to do, though.
And just to connect the adequate use of antibiotics, not using antibiotics when not needed, together with the culture question. First of all, I think it's really important to differentiate surveillance cultures. You really want to know what the patient carries so that when the patient gets sick, and we don't do a lot of that. I think they do much more of that in Europe and so forth. I think we're going to talk about how do you know what kind of bacteria is causing the severe infection, and how do you use the right antibiotics? And I think that we're going to be using more surveillance cultures because we find that these are helpful. But I think it's also important to understand that people have to, not for surveillance sake, but to diagnose an infection as guidance for management, people have to make sure that people qualify for an infection from a clinical perspective first. And in the ICU, we see a lot of patients who are suspected of having pneumonia, for example, who don't really have the clinical criteria to actually have them have pneumonia. And so any culture that will drive treatment may be driving unnecessary use of antibiotics. And those patients are at high risk of infection. So a future infection, when they actually do need the antibiotic, may be harder to treat.